Good morning and welcome to our first lecture in our second point of care ultrasound series for physicians and practitioners. We're excited this series to go ahead and get into some of the meat and potatoes that you might be most interested in when it comes to your point of care ultrasound scanning. So the scan that we're going to discuss today is called the Efast examination, and we'll get right to it here. So the objectives for today's lecture is to define what an Efast scan is. It is defined as extended focused assessment with sonography in trauma. Also define its indications and potential findings. We'll also want you to demonstrate an Efast exam on a patient, evaluating it for positive and negative findings. Compare and contrast pathologic findings common in Efast exams such as hemothorax, pneumothorax, pleural effusions, intra-abdominal hemorrhage, pericardial effusions, and hemopericardium. Also, we want you to identify and demonstrate appropriate sonographic access windows to the potential spaces commonly containing evidence of traumatic injury. Quick disclosure before we go any farther, I am a sonographer. I am not a medical physician, and so any references to suggestions of clinical decisions on the practitioner's part made in this lecture comes from the suggestions from the text suggested for this course, and that text is Point of Care Ultrasound 2nd edition, written by Dr. Soni, Arntfield, and Corey. So any clinical decision making is at their suggestion, whereas the scanning information comes from my own experience. So why do we use Efast? So some time ago, the FAST exam was quite popular, and so as it gained in traction in clinical sites, they found that really they could extend that FAST exam beyond just the abdomen and really utilize it to evaluate the heart and the lungs more thoroughly in trauma situations. So at that point, they changed what we formerly knew as the FAST exam to an extended FAST, or an extended focused assessment by sonography in trauma. There's many different reasons that you can use this, but we're typically utilizing Efast exams to do a very fast examination of the thoracoabdominal cavities in patients that have stable or unstable penetrating trauma, as well as stable or unstable blunt trauma. So where does this all fit in? We know that ATLS is still considered the mainstay in emergency medicine. So where can we utilize this along with the ATLS ABCs to make sure that care is optimized and not negated in any way? So what they found in a number of different studies is that utilizing ATLS with Efast demonstrates superiority to primary survey techniques. So those things like palpation, oscillation, using our senses to evaluate, those things have been proven to be less effective than actually being able to visualize real time with ultrasound. So that this Efast exam is used in combination with the ABCs of primary survey to provide optimal care. One of the things to be aware of, however, as with ultrasound, especially as you know, if we've taken any other previous ultrasound classes, ultrasound is only as good as the user that's doing it. So you have to have a lot of comfortability with ultrasound in order to, not get any false negative results or false positives that would otherwise negate the benefits of utilizing FAST exams. So we're going to go and we're going to talk about some patient scenarios, and in order to do this we want to really differentiate when we're talking about patient stability what this means. So for our purposes only, a patient that's considered unstable would have a life-threatening symptomology. They could be in an unresponsive state of hemodynamic compromise, including a transient state in this of compromise. Stable is literally just not unstable. So if they are not unresponsive and if they are not having hemodynamic compromise, then they would be considered stable. Really, in both of these patients, the point-of-care ultrasound can be really helpful. For the unstable patient, it can be utilized to identify where there could be a bleed or a hemothorax or a pneumothorax and immediately treat that problem. In a stable patient, it might not be quite so straightforward, but it can help also guide more of a longer-term approach to care. So for the unstable patient, we can direct immediate diagnosis and decision making, whereas for the stable patient, it can expedite care that the patient would probably eventually get. It can just kind of help you get there faster. So the Efast exam, what exactly are we doing here? So you can utilize a number of different scanning approaches to do your Efast exam. A lot of physicians in the field, your sites might even have purchased you, or you can purchase yourself very mobile devices that you can keep in the emergency room or clinic setting, and you can have sometimes a wireless ultrasound transducer linked with your iPhone, iPad, or other things. And then there's also a lot of laptop type systems on the market that are really mobile and might be very useful to stay in your emergency department. Usually the larger the equipment is, the better the resolution is going to be, and the easier it is going to be to see these things. So you want to make sure that if you are investing in the equipment, that you're getting something that at least you feel confident relying on. So as I mentioned, the Efast exam expanded from just the FAST exam, which included abdominal and pelvic evaluation. It extended in the fact that it's now inclusive of thoracic, lung evaluation, as well as pericardial evaluation. So the Efast exam does everything that the FAST exam does, but adds some lung imaging to it. So our exam that we're going to be completing is outlined kind of here on this little gentleman. So you see the number 1 here demonstrates the transducer in the subxiphoid area. And if you place a transducer in the subxiphoid area transverse, like you can see this particular transducer here, it's transverse across the patient's body. And if you wedge that probe in and angle up superiorly, you're going to see the pericardial area right here. So we call that the subxiphoid view of the heart. And now this is a common area to detect pericardial effusions or hemopericardium, and so this can be a very useful evaluation to see if that patient has tamponade or any other possibly some fluid collecting there in that pericardial region. From there, and now the order that you're doing this in is going to depend a little bit on the patient condition, what their trauma was, and what you're hoping to accomplish. So just realize that the number by which you would do all of these images can be varied depending on what your concern at the moment is. So what we have over here at number 2 is going to be right upper quadrant evaluation. Now if I were to look at this, this would be considered a coronal view, meaning that we're scanning along the patient's coronal plane with our transducer placed vertically or in line to the patient's body. So if I were to slide this transducer up to this region where the top of the transducer were to be just above the diaphragm here, I could do a quick assessment just from that window of the right pleura. Now we know that any fluids are going to settle in the most dependent area of the body. So if this patient were to have a pleural effusion, a hemothorax, something like that, we could evaluate right there, and we would assume or project that the fluid would collect in the posterior aspect of this patient if they're flat on their back. So we want to make sure that we're putting the fluid in the potential dependent space, and then we're actually looking in that dependent space ourselves. So by sliding this up, I can take a look right here. Right there, you can evaluate that lung region for any free fluid, pleural effusion, pneumothorax, hemothorax, and then you can also look for sliding of pleura in this area to evaluate for a pneumothorax, and we're going to talk about that in a moment. From there, you want to just slide your transducer down slightly, and here in this region, you are going to pick up the subphrenic or the subdiaphragmatic space. So you would see the area between the liver and the diaphragm. This would be a common area to see a subcapsular bleed of the liver, and so you're looking for anything that looks like fluid in this particular region, and then by sliding your hand down slightly farther, you're going to be able to evaluate Morrison's pouch or the hepatorenal region, which is the most dependent region in our abdominal cavity. So you would be able to find even usually minimal amounts of free fluid in that region, indicating some sort of rupture or bleed in the abdomen. Then if you so choose, you can go and look in this paracolic area, but they really do suggest that you next go on to the bladder. You're going to evaluate the bladder in transverse by sweeping all the way out of the bladder to the top, all the way out of the bladder to the bottom, moving it to sag or long, and scanning all the way out of the bladder right and left, and looking for any free fluid in this region. Again, in our pelvic region, that vesicorectal area interface is going to be the most dependent area in males. The pouch of Douglas or the uterine rectal interface would be the most dependent area in females. So right here, you'd be able to pick up any fluid collections. Just one quick note, if a female has recently ovulated, it's not abnormal to see some free fluid in that posterior cul-de-sac by ultrasound, so take that into consideration with your scanning. Then we can go up here to the left upper quadrant. You're going to treat this very similarly to the right. You would slide up to get your above your diaphragmatic area here. Again, you'd be evaluating that lung field, looking for pleura sliding to rule out a pneumothorax, and then looking for any fluid collection that could rule out pleural effusion or hemothorax. Then you would slide down a little bit, and you're going to be evaluating the spleen here. The spleen, be aware that it can be slightly more difficult to evaluate than the liver because of its location and its size. So make sure that you're looking in the subdiaphragmatic or subphrenic area, evaluating for any ruptures between the spleen and the diaphragm. And then you'd want to continue inferiorly here, and you're going to evaluate the spleen's interface with the kidney. That is basically going to be your whole abdominal portion of your Efast exam, and each of these images can be obtained usually very quickly. Of course, patient habitus, condition, and all those other things do contribute to this, but most of the time it's not a subtle finding when there is a lot of fluid somewhere. Now, the other two places that we're going to be looking is in the thorax. And when we talk, we'll talk in future lectures about evaluation of the chest and lungs. So we're just going to touch on it here. But knowing that the evaluation of the lung is going to be most efficient when it's done in multiple locations. So because we know that we could have a problem up here in the apices, a middle lobe, a lower lobe, and we would have to look at that particular area to determine if there was any issue in that particular area. So if we've already looked here at the inferior or the costophrenic angle kind of region, we can consider that cleared after the abdominal part of the scan. But then you're going to need to work your way up the rib line here, up to the apex, and evaluate the lungs in multiple regions to determine whether or not that there is any issues in those lungs. The other thing to be aware of is that as you're scanning deep through lung tissue, ultrasound does not do well looking through lung tissue that is aerated. So as you're scanning through the front of this patient's chest, you're going to be very limited into what you can see in the back of the patient's chest. So if you have a high concern that there could be some fluid collection towards the apex of the lung or somewhere mid lung, then you need to slightly roll that patient into an LPO or an RPO and then access it from the posterior aspect of the body, because accessing it from the anterior aspect won't allow you to see what you're desiring here. Now, when you do look at the lung field, what we expect to see is what we call A lines. So if you put your transducer and you place it in the in between the costal margins, and so you're scanning in between your ribs. You'll see a rib shadow, as this is a great demonstration, a rib shadow here and here. Those should be shadowed. That's what ribs look like on ultrasound. What we expect to see between the ribs are A lines. So these are called A lines, and all they are is an artifact produced by ultrasound hitting air. Now, if a lung is fully inflated and full of air, we would expect to see these A-line artifacts. The other thing we expect to see is at the pleural region, right up in here, and we have some more images of this coming, we would expect to see that pleura sliding against the patient's thorax. And if we're missing that sliding, it could indicate that there is actually a pneumothorax. The pleura is collapsed, and while we still might have some air in here, we do not have that that pleural lining expanded. So when you're doing this, this is what you're expecting to see: pleura sliding as the patient breathes, or as the ventilator breathes for them, and then you're expecting these A lines. Now, sometimes you can get something called B lines. B lines are usually occur when there's the lung is inflated, but there's some sort of consolidation in the lung. So maybe they have some pulmonary edema or something like that. Well, because of that, they're having fluid in the lung. Fluid can transfer sound much better than air can. And so the lack of these A-line or ring down artifacts is going to demonstrate that there is really something in there this sound is able to transmit through and bring information back. And that, while that's usually a really good property when we're using ultrasound, it's not a normal property of the lung. We call these B lines. And in order to diagnose B lines, you need to find these in multiple, meaning greater than 2 different rib spaces. Okay. The other thing you're looking for, and this is probably the very most prominent, you set the transducer down, you see a collapsed lung here, and you see a lot of fluid, which is our anechoic area here. That would indicate that we have a pleural effusion or possibly a hemothorax. Now, when blood is early in the bleeding stages with ultrasound, it really appears very similar to just a regular serous fluid, so you'll see it very anechoic like this. If it's an older bleed, it tends to begin to organize, and it will start to present much low-level echoes, and then as it gets more and more mature, it becomes more echogenic or bright. So if you see something like this, it really could be serous fluid, it could be, or it could be blood. Here's just an example too. Lots of times when we're looking at those phrenic areas, so here would be subphrenic, here's supraphrenic. We see the liver and ascites, or liver and some sort of fluid here. And then we see lung and a pleural effusion here with the diaphragm separating the two. When I was speaking earlier about the lung point and what you're looking at, is here you can see a rib shadow. Here we see those A lines as you look down, and if we were to watch this interface right here, you would actually see sliding up and down, which is something, again, we'll go over more as we evaluate specific chest sonography. Now here's an example of a pneumothorax where, again, you kind of get these A lines because there's some air in there, but you're never going to see that the sliding of the pleura there. So those are the things you're going to be looking at as you scan. Now we're going to take a look at exactly how Efast can be incorporated with the ABCs when in patient care to see how exactly this would be utilized to optimize the patient outcome. And these scenarios are going to be supported by information in that point of care ultrasound text recommended for the course by Sony, Arntfield, and Corey. So if you have further questions or need more specific scenarios to help guide you, that is a great resource to look at. So our first scenario here is that we're going to have an unstable patient. So it's a hypotensive patient with tachycardia and unknown trauma. So the first part of our ABCs is airway. So with airway evaluation and treatment, really ultrasound is a very limited use. And so one of the features that could be utilized to by ultrasound to assist in this this part of the assessment is going to be to evaluate for endotracheal tube placement. It can be limited in how useful this is, but it is definitely an option there, especially once you've had some experience and able to utilize it more confidently. But really where the EFAST comes in to be very beneficial is in the B's. So when we get to breathing, we can utilize ultrasound either prior to or in addition to a portable chest x-ray. And the ultrasound may be able to identify pleural effusions, hemothorax, pneumothorax, pericardial effusions, or hemopericardium before an x-ray could even be obtained. It's so quick, it's just so available bedside. It's not like rolling in the portable chest x-ray, having to wait for the room to clear and obtaining that. It's available and it's right there, so it can be completed very, very quickly. And the other benefit of this is that it can detect very, very small volumes of fluid collections. It's much more sensitive than a chest x-ray in that case. We know that most of the time, a patient that's this unstable is probably going to be in the supine position, and we would be getting a portable chest x-ray without the patient erect, making those fluid levels even harder to detect. And so in that case, the ultrasound is going to be quite a lot more sensitive to those fluid levels than our chest x-ray would be. So it's a great option to, again, use instead of or in unison with a portable chest x-ray. Another thing that we can utilize the Efast exam for would be to evaluate the abdominal viscera and thorax, looking for a ruptured diaphragm or evaluating any potential areas of hemorrhage. Now, that will be addressed more here when we get to the C's for circulation. And then if we are able to find the cause of some breathing instability, those things can be addressed immediately right under the direction of ultrasound to stabilize that patient in optimal care. Now, when they get to circulation, if the patient is unstable in the circulatory system, ultrasound can be used to evaluate for occult hemorrhage with cardiac or abdominal pelvic imaging. So in this case, you would want to evaluate the subxiphoid cardiac view to look for any fluid collections in the pericardial area. And really, they recommend that all fluid collections are treated like hemopericardium until otherwise diagnosed. Okay. So if a pericardial effusion is noted, intervention can be immediately considered, allowing immediate treatment to that patient, removal of that pressure around their heart, looking for an improved patient outcome. Once the cardiac area is evaluated, especially with that subxiphoid view, then they recommend that you move on to abdominal and pelvic views. And these we talked about already when I demonstrated the windows that you would be utilizing to obtain these images, but most would start in the right upper quadrant in a coronal sort of position, and you would demonstrate that right subphrenic space, and in that same image you can see the right inferior lung as well. So if you haven't already assessed that right inferior lung, you can reassess it right here. And then you'd want to move inferiorly to look at the hepatorenal interface, also known as Morrison's pouch, as that is one of the most prominent potential spaces where fluid usually collects. And then finally, the inferior renal pole. From there, you can either move to the left or you can go down to the pelvis. If you go to the left, you would want to access the left upper quadrant in a coronal scanning plane as well. Here you can demonstrate that left subphrenic space. If you're at the level of the diaphragm, you can also evaluate the left inferior pleural spaces in the same imaging point. Then you want to move in inferiorly and evaluate the splenorenal interface. This one can be a little bit more difficult to detect. It might take some adjustments of moving the transducer and finding different windows to identify this area, especially in some of your larger patients. And then from there, you're going to move down to the inferior renal pole, and then finally to the pelvis. And in the pelvis, Some people will choose to look at the paracolic gutters, as those are potential retroperitoneal or extraperitoneal spaces. Others will go just directly to the bladder and evaluate that bladder completely in long and transverse. Now you notice we're not evaluating the actual abdominal aorta, and part of the reason of that is if there is some sort of bleed from that abdominal aorta, it's going to be demonstrated with fluid collection in some of these potential spaces. So this is just the briefest, most direct way to find that fluid so that it can be addressed as quickly as possible. And now, if the patient is still unstable in their circulation and all of the evaluation of the abdominal area is coming up inconclusive, it might be prudent to look for long bone fracture with vessel rupture, which is going to be most common in the pelvic or femoral area. And they say really that ultrasound, while you can look for any fluid collections in that area, but usually with those significant femoral fractures with vascular compromise, you're going to often see those clinically, with the contusions in the skin and changes in the thigh color at that point. So hopefully that gives you some ideas of how you would implement the Efast exam with your trauma patient in an unstable state. Now we're going to look a little bit at a different scenario where the patient now is stable. Now we know that a patient that's currently stable doesn't guarantee that they're going to stay stable, and so some of the purpose of this Efast exam is to identify any upcoming issues very early so they can be addressed before it becomes a serious scenario. So in this scenario, we have a normotensive patient with thoracic trauma demonstrating satisfactory cardiorespiratory function. Again, we're going to begin those ABCs, and with the A, airway, we know that really no sonographic assessment is that useful or necessary, especially in this case. Now, if that patient were to go to an unstable situation and you had to address the airway, then sonography could be used to evaluate ET2 placement. But in this case, the patient's staying stable at this point, so we're going to move on to breathing. Now, with breathing, again, the Efast exam can be used in unison with the portable chest x-ray, and you'd want to start with a 6-point thoracic assessment. And we're going to look at those windows. Just because we see normalcy in lung in one area doesn't mean that it is a normal lung throughout the whole thorax. So now this 6-point thoracic assessment is utilized in the unstable patient and really any type of chest ultrasound that we do. We're going to go into it more in future lectures, but the idea is that you're going to be really starting at the apex, the mid thoracic region, and then in that inferior thoracic region as well. So you're assessing each part of the lung separately to ensure that you're not missing any particular area of concern. Now, we do know that fluid is definitely going to settle in the most dependent area. And so it can be important for these is if you're scanning posterior on the patient as well as anterior. So you might want to take a look at the lung, how we described earlier in this lecture, at the apex area anteriorly, and then roll the patient up very slightly to assess it posteriorly, because that's posterior is where you're probably going to find any of the fluid. And you would want to repeat that process at the apex, mid-lung, and then, of course, at the inferior lung, and do that both sides, and that's how you're getting that 6-point thoracic assessment. When you're assessing it, you're really looking for the lack of pleural motion. That lack of pleural motion would demonstrate a pneumothorax. You're going to be looking for those A lines, demonstrating whether the lung is full of air or not. And you're going to be looking to see if there's any fluid collection. So once you have that complete, you can definitely then evaluate the intraperitoneal viscera and the thoracic cavity. If the patient has had trauma at the diaphragmatic level, It might be prudent to go to laparoscopic investigation despite the ultrasound findings. However, that would be your clinical assessment and decision. But because sometimes it can be very difficult to detect a diaphragmatic rupture, something like that, by ultrasound. Not impossible, but definitely challenging. One of the things you'd want to look at for a diaphragmatic defect would be, if you're starting to see, of course, any abdominal viscera herniating into the thoracic area, of course, then that would indicate that there's some sort of disruption of the diaphragm. But something more subtle would be much more difficult to identify. If abnormal breathing, intervention should be immediately administered. If normal, if you have a normal scan or an inconclusive scan, it can be prudent to either complete serial Efast exams or serial portable chest x-rays for 6 to 8 hours to make sure that the patient's state does not deteriorate. In this same stable patient, we're going to then move on to circulation. And so here we're really looking for any sort of bleeding of the patient. So the first place we're going to start in our circulation is at the heart. And so you're going to utilize that subxiphoid cardiac view, angling the transducer up under the xiphoid process and evaluating the pericardial space, looking for any sort of fluid in that region. And obviously, if there's any fluid there, it's going to be assumed that it is a hemopericardium until proven otherwise. So if pericardial fluid is noted, intervention such as a thoracotomy can be immediately considered. Now, if the pericardial area appears clear, but you still want to continue evaluation of circulation, then you can again evaluating the right upper quadrant, as we talked about before, the left upper quadrant, and the pelvis. If free fluid is identified in a trauma scenario, it's most likely blood, intestinal matter, or urine. And by evaluating that bladder, it's going to give you a real clue whether to have concern that this is urine or blood. The current recommendations indicate that all free fluid diagnoses should go to surgery. If the exam is negative or inconclusive, again, you can go to serial observation, or depending on your level of concern, send the patient to laparoscopy to determine if it's a true negative or not. Okay. Next patient that we're going to look at here is utilizing the Efast exam with a trauma arrest. And so a patient's in emergency department after a motor vehicle collision. They become comatose and pulseless, and CPR is initiated. So how are you going to use your Efast in this scenario? These may be the hardest to first begin trusting the Efast in because it's such a stressful situation in the first place, but it can be of excellent help to you. So first thing you're going to do is start with your ABCs. So evaluate the airway and address any issues here. Obviously, there's an issue if your patient is comatose and pulseless. So our purpose of ultrasound in this area would be just to verify the endotracheal tube placement if desired. Next is breathing. So if there is obviously no breathing at this point, they recommend that you don't even start with the Efast exam, that you would place bilateral thoracic tubes and move on to circulation. Circulation is so important at this point. Hypovolemia would be suspected due to the patient's scenario. So this is where you're going to bring your Efast in. So you would start right at the subxiphoid cardiac area and angling upward, evaluate that heart to see if there is any pericardial fluid. Now here's where recommendations bifurcate a little bit. At this point, they do recommend that you use a transesophageal echo to be more accurate. That's an ultrasound that's advanced down the esophagus, providing very close access to the heart to evaluate it with the greatest amount of detail. If you have that capability, they recommend that you utilize that, as it's much more sensitive in this very serious situation. But you know, a lot of critical access hospitals, they're not going to have those kinds of things available. So you can still utilize your general scanning probe, evaluate through the subxiphoid area, looking at that heart. And the following are, again, recommendations from that text with Sony, Arntfield, and Corey. So they say consider resuscitative thoracotomy or resuscitative endovascular balloon occlusion of the aorta, depending on the surgeon and institutional protocols. So if you think that the circulation is compromised, they recommend just addressing that bleed or hemorrhage immediately before considering anything else. Now, if you wanted to go ahead and look at utilize your ultrasound to look at cardiac activity, again, you can access it through the subxiphoid area. If you find positive cardiac activity with a massive hemopericardium, then they recommend resuscitative thoracotomy. If you have positive cardiac activity without hemopericardium, then they say that you go right to the RIBOA. And if you have negative cardiac activity at this point, they recommend termination of resuscitation, which is an interesting, interesting recommendation. And so they did provide the context of why that is the recommendation, and they had done a 4-year study where they found that 100% of cardiac activity or negative cardiac activity on that initial ultrasound was associated with death despite any additional interventions. Only 5% that had cardiac activity identified in this situation survived, and they were treated with the resuscitative thoracotomy or the RIBOA. So at this point, this patient's in serious, dire situation. If in utilizing your sonographic assessment can help you make some of those very difficult decisions. Now, you might ask why we just mentioned that this patient was pulseless, and yet we're referring to positive and negative cardiac activity. Obviously, it would be if that cardiac activity was too weak or there was so much tamponade that it was not able to produce a pulse. It doesn't mean that the heart is still not functioning, at least to a certain extent. So in summary, those are just a few scenarios of the millions of different things that you all encounter in clinical daily. So just in summary, we'll kind of wrap up some of what we talked about today. Again, please share with your peers how you're utilizing the Efast exam. Start to implement it on a level where you're comfortable until you feel like you can where you feel like you can apply it in any scenario, and that's when it's going to become the most useful tool for you. So Efast is a useful tool when carried out as a supplement to the ABCs in trauma medicine, especially useful in the evaluation of circulation because it provides us such quick access to the heart and looking for that free fluid that would indicate any sort of internal hemorrhaging. Serial Efast exams can be really useful when the first is negative or inconclusive, or if the patient's condition changes. Now, we do know that ultrasound takes a long time to learn and become competent at, much longer than most people appreciate. And so just because you get a negative, especially if you're early in your processes of completing these exams, it doesn't mean that there couldn't be a small bleed or couldn't be something happening there. So really those serial exams will help provide optimal care, and so they're a very low risk to the patient. There's no radiation, they're very fast, they're inexpensive. It's really just finding the people that are qualified to complete them that is the challenge. With unstable patients, we'll do a really brief summary. So this was the first scenario we talked about. So with our unstable patients, you'll want to, and you find a positive abdominal Efast exam, they recommend you go immediately to a laparotomy. Positive cardiac findings would necessitate a sternotomy. False negative cardiac findings could occur when a hemopericardium is draining into a hemothorax. A negative exam in an unstable patient raises suspicion for retroperitoneal, and external hemorrhage, and so laparotomy, REBOA, or diagnostic peritoneal aspiration may be considered. And again, this is probably a false negative, but you should get less and less of those as you become more confident in your scanning. In that patient that's a stable trauma, absence of sliding pleura is specific for a pneumothorax, but it has to be assessed at multiple rib levels. Normal lung sliding or indeterminate lung sliding should be reassessed at 6 to 8 hours with serial Efast exams or portable chest x-rays, looking to see if there really is a pneumothorax there or not. Pericardial fluid is assumed to be hemopericardium until proven otherwise with operative exploration. Positive abdominal findings necessitate laparoscopy in non-cirrhotic patients. And then an occult pneumothorax in trauma may not require thoracotomy and can be observed with serial imaging, saving the patient from the invasive procedure. If free fluid is detected in abdominal or pericardial areas of a stable patient, stability should be reassessed and a CT and echo should be performed right away. So I really appreciate you all joining me for this first lecture. Again, this is just a kind of a brief overview of the use of our Efast exams, but get in there, utilize your transducers, and get comfortable with them because they can turn out to be a really great tool. So thanks for joining me. We'll talk to you next week.